And it's a great pleasure to introduce now Professor Andrew Coates, who is the president of the Heart Failure Association of the European Society of Cardiology. And unfortunately, he was not able to be with us because he's still confined in Australia and he cannot leave, but he will talk about sleep apnea. Please, Andrew.
Welcome. I'm Andrew Coates, President of the Heart Failure Association. Great pleasure to present at this heart failure program, recent updates, new guidelines. I'd like to talk about sleep apnea. First of all, sleep apnea is very common in the general population. It affects about a quarter of all men, about 10% of all women in middle age, and severe sleep apnea is about 15% of middle-aged men and 5% of middle-aged women. These are people who stop breathing, 120 times or more per night. If sleep apnea, however, has actually got two forms. The most common one in the normal population is obstructive sleep apnea. And as shown here, what the problem is the airway blocks off during sleep. So the soft palate falls back, the tongue falls back, and there's a blocked or closed airway. So the effort is to open the airway, and that causes noisy breathing. It causes intermittent, as the name suggests, obstructive apnea. The other form, however, is a central sleep apnea, where the airway does not close, but there's a loss of normal control of breathing. So it's a neurological problem in that the brain doesn't send regular signals to breathe. It oscillates between under-breathing or no breathing and over-breathing. The problem in heart failure is that both these forms of sleep apnea are common in heart failure, but they vary with the severity. In very mild heart failure, the majority of patients have obstructive sleep apnea. Around about 50% of patients with heart failure have sleep apnea, but in very mild heart failure, it's predominantly obstructive with very small number of central. But as you get more severe heart failure, the majority of the sleep apnea becomes central. And sleep apnea can affect up to 2/3 of patients with severe heart failure, particularly with a reduced ejection fraction. Now, the established treatment for most sleep apnea in the healthy middle-aged population is what we call a positive pressure airway system, where a series of masks that can be either the nose or the mouth can blow positive pressure airway in, and that keeps that obstructed airway open. It prevents the tongue flopping back, and hence you don't get obstructed airway. This is a very effective treatment for obstructive sleep apnea and dramatically improves the quality of sleep and can improve daytime awakeness. You can see, however, that most sophisticated version of this positive airway pressure, the adaptive servoventilation, also works in central sleep apnea. So we see here, this is the classic oscillating breathing pattern of central sleep apnea. And we see airflow measurement when the auto-set adaptive servoventilation is operative, normal breathing pattern. As soon as you switch off that positive pressure airway, the oscillating pattern of central sleep apnea starts again. So the positive pressure airway mask, although it was originally designed for obstructive sleep apnea, is also effective for central sleep apnea. Because it's so common in heart failure and because the presence of sleep apnea is an adverse prognostic marker, there was a very important trial called SERVE-HF that used that adaptive servoventilation form of positive airway pressure to treat patients with heart failure and reduced ejection fraction and predominantly central sleep apnea. It was designed to see a significant benefit. The primary endpoint, however, at the end of the trial did not show a benefit. It actually showed a tendency to harm with a hazard ratio of 1.13 on the probability of a composite endpoint of cardiovascular death and heart failure hospitalization. In this trial, however, death from cardiovascular causes showed a significant excess of 34% extra risk of dying from cardiovascular causes, which had a p-value of 0.006. So, of course, from that date, it was an absolute contraindication for patients with heart failure and reduced ejection fraction and predominantly central type sleep apnea to be treated with positive airway pressure mask of this nature. The question is, why did a treatment that's very effective at abolishing sleep apnea, central sleep apnea, when we know that central sleep apnea is an adverse prognostic marker, why did it not reduce mortality? Indeed, why did it actually make mortality worse? This was a surprise to the investigators, and two main theories have been proposed. One is that central sleep apnea, in the form of one particular type, Cheyne-Stokes respiration, is actually a compensatory mechanism and may be beneficial to patients, hence causing harm if it's removed. And the other explanation is that the positive airway pressure needed to control this form of central sleep apnea was harmful because the pressures were so high, it caused an increase in intrathoracic pressure, which impeded right ventricular function. Now, to review back, central sleep apnea, we know increases mortality. Here we see patients with central sleep apnea more than 5 episodes per hour. If you look at cumulative survival in patients with heart failure, you see those with an elevated rate of central sleep apnea have higher mortality. And it's a graded effect. The more episodes of central sleep apnea per hour overnight, the worse the survival. Also, there was one earlier trial called CANPAP that used another version of positive airway pressure in patients with heart failure and central sleep apnea. And that was a neutral trial as shown here, a small trial. The CPAP group had 32 events, mortality events, the control group's the same. But when they looked at those patients who had treated and abolished their central sleep apnea, they did extremely well. It was the patients who were treated but still had residual central sleep apnea who did badly. That suggests that the central sleep apnea cannot be a beneficial thing because the patients in whom it was abolished were those with the best outcomes. So how do we explain this discrepant result? Well, I think we need to look into a bit more detail. And actually, central sleep apnea is of two types. It is the regular type that I've shown, the oscillatory breathing down the bottom, that's the Cheyne-Stokes type. Whereas there's another form, which is an irregular central sleep apnea, where there's not a rhythmic pattern, but isolated and irregular episodes of apnea, and they responded quite differently. If you look at the supplementary data of the SERVE-HF trial, you see that patients with predominantly Cheyne-Stokes respiration, those who had between 20 and 50% of their episodes being Cheyne-Stokes-like or greater than 50, had significant harm, but those patients who had the non-Cheyne-Stokes type had significant benefit. So the treatment works only for the irregular central sleep apnea. It appears to be harmful for the regular oscillatory Cheyne-Stokes pattern. And the reason for that is the Cheyne-Stokes pattern is very hard to suppress. So the device kept trying higher and higher intrathoracic airway pressures to suppress the central sleep apnea, and that impeded, we believe, right ventricular function, increasing mortality. There is, however, an alternative, and that's a simple implantable device called the Remedy system that is like a pacemaker, but it's designed to stimulate the phrenic nerve, causing a diaphragmatic movement, hence causing a breath in a patient during apnea. The difference with that and the positive pressure airway mask is that in normal breathing, the diaphragm pulls down, causing a negative intrathoracic pressure. In the mask therapies, air is blown in, causing a positive intrathoracic pressure, whereas the Remedy system, by stimulating the diaphragm, mimics normal breathing, so it causes the opposite type of pressure change. It mimics what happens in normal and is the opposite to the positive pressure airway mask. The Remedy system, when it's stimulated on, can suppress his oscillating breathing quite quickly, there within a few seconds, and it is an effective treatment of central sleep apnea. This was evaluated in a pivotal trial, 151 subjects in Europe and the US, and it was looking at a primary effectiveness was the proportion of patients who had a reduction in the number of apneic episodes between treatment and control. And you see here, looking at individual patients, the improvement in the apnea index was much greater in the treated patients, with only a small number getting worse, compared to the control patients, where a very large number of patients got worse. So it was a highly significant benefit. The proportion of patients who improved was much higher in the treatment group compared to the control group, with a p-value of 0.0001. Also, patient global assessment was dramatically better, with the patients treated being much more likely to be markedly improved, moderately improved, or mildly improved, compared to a substantial proportion of control patients being significantly worsened or markedly worsened. In addition, other endpoints of interest are sleep apnea, central apnea events per hour, apnea hypopnea index per hour, arousals per hour, the percentage of rapid eye movement sleep, which is beneficial, and oxygen desaturation events were all significantly improved, as was the best quality of life score for sleep apnea, the Epworth Sleepiness Scale. So all these secondary endpoints were significantly benefited. In addition, there was a substantial number of patients with HFrEF in this trial, about 2/3, and in those patients with NYHA class greater than 2 and an ejection fraction of below 45%, these same respiratory endpoints were significantly benefited, as was the improvement in the patient global assessment and the oxygen desaturation episodes and the Epworth Sleepiness Scale. In addition, shown here, we also saw that dramatic improvement in the quality of life, markedly and moderately improved compared to deterioration in the control group. And they were highly significantly benefits, both in terms of sleep metrics, sleepiness scale, and overall patient global assessment. The guidelines in 2016, which have not changed much in 2021, suggest that this positive airway pressure should not be used in heart failure with central sleep apnea. ASV, the adaptive servo ventilation type, is not recommended, and therefore you need to assess your HFrEF patients to see if they have central sleep apnea, and then try alternative approaches such as the implantable phrenic nerve stimulator, the Remedy system. In summary, phrenic nerve stimulation provides statistically significant and clinically meaningful benefits. Treating sleep apnea, a common complication of our HFrEF patients, and is the only safe way to improve the quality of life through this mechanism. There's an improvement in overall patient global assessment, as well as an improvement in daytime somnolence, daytime awareness is improved, and a very good safety profile. We await further large-scale trials to look to see whether this has a benefit in overall outcomes for patients with heart failure. Thank you very much.
Thank you. Thank you very much. Unfortunately, Prof. Andrew is not able to be with us, the time difference. Let me ask the co-chairs here. So we have maybe 3 types of sleep apneas. So the commonest one is obstructive, then central. How do you, Dr. Juwairi, Dr. Ozano, how should we assess this when somebody comes to us with heart failure? Should we do that at the first visit? When should we ask about this?
I mean, certainly it's a clinical decision, and sometimes you see the patient and he screams sleep apnea to you. So you can send him for the assessment from the beginning, but you don't want to send him while he's volume overloaded. So you want to treat the volume overload and then send him while he's able to do the test appropriately. But if it's not, usually the first visit in heart failure, there's a lot of things that you go through. You go through the treatment plan, you go through the risk factor modification. It's a very exhausting first time. So probably would leave it if the patient clinically does not look like a sleep apnea patient, then you would visit that again the second or the third time, because you already have so many things to talk about the first time, right? So you just ask the questions, do you snore, do you wake up at night? Some of them could be similar between heart failure and sleep apnea. But you can reassess that, I think, later.
More dangerous, central or obstructive?
It depends on the severity, of course, and depends on the duration of the apnea and on the overall burden of apnea. And what is important is sometimes are either the wives or the husband that tell you about the sleep apnea. Because they're more worried, and they say, I got worried at night because it stopped breathing. So, and that is when you suspect. The other thing is that you can suspect when they tell you that they are tired in the morning. Yeah. When they say, I wake up, but I'm tired early in the morning. That is a very important sign where you have to start thinking about the presence of sleep apnea.
Any in the audience here got experience of how to tackle Dr. Sharif?
It's not experience, but it's the problem in the sleep apnea. It is very difficult to treat. I mean, it's very easy to say, Because most of patients who are whatever heart failure or not heart failure, when you send them to do sleep test and then they come back and they advise for them to sleep with about maybe 80% or 85%, they are not able to tolerate the way that they have to treat. So the question is, what is next? Yeah, and most of them, they do a lot of adjustment for the mask, and at ended, I think all of you find it in your practice. At the end, you will find that he's not using the machine at night. So what to do? Of course, we know that you have sleep apnea. We know there is a treatment, but it cannot be applied because of a lot of complications. So what is next?
It depends whether it's obstructive or not. And of course, we'll wait for the results for the central, for the phrenic nerve stimulation to see whether that will have a significant effect. In those patients who cannot tolerate the mask, there is the very old system of the tennis ball. Do you know that basically you have the tennis ball that is sewn on the back of the pajama, so that basically it makes the patient sleep on either sides. And it works. I mean, it's but of course it doesn't work like the CPAP. So CPAP, of course, but there are those patients who absolutely refuse it. I mean, they cannot tolerate the mask. Some of them, they cannot tolerate the noise, and that can be another possibility. There are other new devices. I mean, some sort of smartwatches and small devices that you put under the pillow that vibrate. Unfortunately, as in any non-medical device, these devices have not been tested enough in order to see whether they're effective. So they claim, but the real efficacy is very small.
Yeah, I mean, thinking about it, central apnea, which is you have no signal to tell you to wake up, at least obstructive, you wake up, but really worrying. So thank you very much, both of you.